Good evening. Today I shall be giving a brief outline about Parkinson's disease and in the first part of this video, and the next part will be on a same topic pertaining to uh, the remaining things. So today I'll cover a brief idea about what Parkinson's disease is, how to diagnose. Now, you see, basically in neurology, the disorders of the nervous system, they are grouped into certain topics, and there is a topic which is known as movement disorders. So anything pertaining to disorders of our movement, this can be grouped into two headings, broad headings. One is where there are things which are because of increased activities. So for example, these are known as hyperkinetic movement disorders. So hyper means more, so hyperkinetic movement disorders. And the other group, just the opposite, the way the patient becomes very slow and the movement becomes very less, and these are known as hypokinetic movement disorder. And classically, Parkinson's disease is one of the hypokinetic movement disorders, also known as akinetic rigid syndrome. I'll come to the individual points later. The brief thing is that about the history is that this was way back about say 3 centuries before, when a surgeon named Sir James Parkinson, he found out that during his surgeries in the operation theatre, he was unable to be that much effective as before, and because of the hands shaking. So he observed his course of the illness over the years to come, and surprisingly, this description of his own disease is still apt today. So a Parkinson's disease, being a classical neurological disease, was actually initially highlighted by a surgeon. Now, let us come to the disease proper. So Parkinson's disease is a disease where the pigment in a particular area of the brain starts degenerating, and this pigment is very essential for certain movements of ours, and so the reflection is on the movements as such. So this area in the brain is known as substantia nigra, where these particles which give the color of that particular area of the brain start degenerating. The most important chemical mediator here is dopamine, and dopamine is a substance which is very concentrated in both our emotional area of the brain, which is known as the limbic system, and in the areas which function in the motor activities of ours, so in the basal ganglia and the substantia nigra. Now, being say degeneration of those pigmented cells will ultimately lead to a deficiency of dopamine within the brain circuitry, leading to these features essentially clumped up together into a disease syndrome known as Parkinson's. So Parkinson's proper, the disease proper, is this, but there are several other diseases which mimic the certain features of Parkinson's, and they are known as Parkinson's plus syndrome, which I'm not going to not discuss today, on a later date. So what are the cardinal features of Parkinson's disease? So a patient initially starts developing certain fine movements of the hand, fine as well as coarse movements of the hands or limbs or lips or head together. So these are known as tremors. Now tremors means shaking, so this disease was also known as shaking palsy. Now tremors can be of several types because of involvement in certain different areas of the brain. So they can be initiated by a movement, or they can be at rest, or they can be with certain end point of the movement. Depends on the particular areas of the brain which is giving rise to the tremors. In Parkinson's, this is a classically resting treatment. That is, when the patient is sitting idly, it can be seen by the observer that his hand, usually the disease is asymmetrical, so one side starts with and then proceeds to the next side. So one hand is shaking on the table as such. Immediately when the patient wants to do some activity, this shaking stops. So this is classically which differentiates it from other types of tremors. So first and foremost, tremors. So in Parkinson's, there are four cardinal features. Number one, tremors. Number two, bradykinesia or less movement. So a patient takes a long time to get up from the seat, or to button his clothes or unbutton his clothes, to eat his meals. And it seems to the attendants or the people around him that something is unusual. Either this man doesn't respond properly immediately, something is going wrong. So this is the reason why the patient is brought first, and this is one of the cardinal features, most important features of Parkinson's disease, that is bradykinesia. That's how it got its name also, hypokinetic movement disorders. The third is rigidity, or the patient's body becomes more rigid. So as if the patient, the hand movement, the leg movement, all becomes very tight, and the patient can feel it when he gets up in the morning, rolls in the bed. This becomes very difficult for the patient. And the last and most important thing is the gait, or the walking. The walking changes. The patient gradually begins to stoop forwards, and the classical description is that the person chases his center of gravity. So it's a short stepping gait and then shuffling. So it's a typical type of gait, walking with just step by step, just as if the very careful, very conscious about falling and all. So this is the typical gait of Parkinsonism. These three features, the rigidity, bradykinesia, tremor, and the gait, is finally clumped up with one important thing, which is loss of postural reflexes. So the patient do not have proper reflex to stand, to walk, and may have a tendency to fall. So these are the four cardinal features of Parkinson's, among which we do not aim to treat all, but some important aspects have to be treated. For example, the slowness, the rigidity. Tremors are also sometimes essential to be treated, but the other things are mostly left to particular type of neurophysiotherapy. How to diagnose if the patient comes with these kinds of features, and along with that, if the patient has these elements of falling and all, then of course the diagnosis is done. It's a clinical diagnosis. There is no hard and fast scan or imaging or anything, any blood test or anything is not required. It's a disease, it's a diagnosis which is based totally on the clinical history and the clinical observation. But said and done, these days there are scans which can highlight the loss of the pigment inside that particular area of the brain. So there are different type of nuclear scans, which is known as DAT scan or things like that, but they are more of academic interest, not for diagnosis in routine clinical office practice. So the main idea today about highlighting on these particular features is that people who are experiencing such a patient at home, be aware that it is not because of certain dementia or forgetfulness or some depression or this that the patient is becoming slow. So the patient is becoming slow. Along with that, the typical gait is there, typical walking changes. Then, of course, the tendency to fall and the tremors. So all these put together, the doctor must. Now, there are certain other features of Parkinson's disease which do not need to be discussed with in this forum. It's more of an academic interest, because these are diseases. This is a disease which is of the motor system. That, as I told you at the onset, that this is a disease classified in movement disorders. But there are a host of complaints which come in Parkinson's, which are known as non-motor complaints of Parkinson's, which are later in the course of the disease. It's like for problems of sleep, problems of memory, problems of psychiatric illnesses like psychosis. These are definitely going to come, but maybe over a period of 5 years, 10 years, or down the line. Now, Parkinson's, last and this thing I will tell you that as regards the treatment part is concerned, I'll discuss this on another day. But all said and done, one must remember this is not a killing disease. This is a crippling disease. So one must try to develop this intention that the person has to live with it, with the proper medications time to time, and along with the proper kind of physiotherapy, the person can definitely lead a normal life for years together. One has to be careful in diagnosing the disease and differentiate it from other diseases like Parkinson's plus, which mimic most of these features which I told you, but may not have all of them. As I said, in the non-motor symptoms, one very usual problem is that later in the process of the disease, the patient loses control over his bowel or bladder, and those are neurogenic bladder or neurogenic complications of Parkinson's which come under the non-motor symptoms. So I'll sum up like this: that one must know that yes, this person at home behaving, having these kind of problems definitely has certain features which requires the help of a neurologist, and the neurologist must be careful that these are features summing up into a broadly into a group of disease which is hypokinetic movement disorder, of which this is probably fitting into all the cardinal features of Parkinson's. From there on, we'll take up on the next day regarding the treatment and the recent developments in the treatment. Thank you very much and a very good evening.